My name is Cora Peck, and I serve on the board of directors for the nonprofit Pudendal Neuralgia Association. We're honored to welcome you to today's webinar with Dr. Ashley Gubbels. It's focused on laparoscopic decompression surgery for pudendal neuralgia. For those who may be new to our community, the Pudendal Neuralgia Association is dedicated to supporting individuals affected by pudendal nerve pain through education, advocacy, and connection. We raise awareness through medical conferences and provide safe spaces for patients to support one another, including our monthly Zoom support group, where lived experience and empathy take center stage. So Dr. Gubbels earned both her undergraduate and medical degrees from the University of Minnesota. She completed her OBGYN residency at the University of Nebraska Medical Center, followed by service in the U.S. Air Force as a general OBGYN. She later pursued a fellowship in minimally invasive gynecology with a focus on chronic pelvic pain at St. Joseph's Hospital in Phoenix, Arizona, under Dr. Michael Hibner. She joined the Cleveland Clinic in 2022 and became director of the Chronic Pelvic Pain Program in 2025. Dr. Gubbels also serves as vice president of the Pudendal Neuralgia Association. We're grateful to have her here today to share her expertise, her surgical insights, and her commitment to patient-centered healing. Dr. Gubbels, thank you again for joining us today. We're so grateful to have you here to share your expertise and insights on laparoscopic decompression surgery. And I'll now turn it over to you for your presentation.
All right, thanks so much for having me. I'm gonna work on my screen share. Okay, you have a full screen of my PowerPoint.
Yeah,
Okay. All right.
perfect.
So again, Ashley Gubbels, I'm at the Cleveland Clinic in Ohio. And tonight we're talking on laparoscopic pudendal nerve decompression and post-operative care. Let's see. All right, so I'm going to repeat some things that many of you, probably already know, but I think it's helpful when you understand what it is that we're doing surgically to this nerve. So the pudendal nerve arises from the sacral portion of the spinal cord. So it's the S2, 3, and 4 nerve roots. And real quick, Cora, can you see my my cursor on the screen at all?
Yes, I can.
Yes. Okay, perfect. So the S2, 3, and 4 nerve roots, and those combine to form the pudendal nerve. It's both a mixed sensory and motor nerve, which means that you can't do certain things to it like you can for nerves that just are sensory. So such as nerves in the back, you can do radio frequency ablation and completely destroy the nerve with no major impacts. This nerve, unfortunately, you can't do that too, and so it makes it a little bit more difficult to manage. So the sensory component covers the clitoris, the distal vagina, perineum, and rectum. Obviously, I'm a gynecologist, so I mostly take care of women, but in men, also the penis, the scrotum, additionally. From a motor standpoint, it controls our external urethral and anal sphincters, so the sphincters that are under our conscious control, as well as some of our perineal muscles, or the levator ani, which is some of the pelvic floor muscle. And then it has something called autonomic innervation, which is the part of our nervous system that we don't consciously control. So in this instance, initiation and maintenance of erection and that conscious sensation of the need to urinate or defecate. So as I mentioned, this nerve comes off the, let's see if it's going to work, S2, S3, and S4 nerve roots. It joins up just before it passes under the ischial spine to form the pudendal nerve. And then branches into 3 different branches, one going to the clitoris or penis, one going to the perineum scrotum, and one going to the anal area. So just a different view is if we have you on the bed in a lithotomy, the nerve branches out along the sits bone, so the ischial tuberosity comes out and then sort of splits into 3 different branches, so both in men and women. And that branching can be quite variable from individual to individual. Some of it occurs up in the pelvis, and other individuals it occurs much lower down. And so again, just a brief overview of sensory innervation. So the areas where patients will feel pain is essentially the genitals. And these are the only nerves that very specifically innervate the genitalia. In terms of pudendal or Alcock's canal, this is formed by a splitting of one of the membranes that is overlying our obturator internus muscle, which is one of the muscles that helps us rotate our thigh. And that goes essentially from just after the ischial spine here, which is attached to the sacrospinous ligament, and then travels down to the sits bone or the ischial tuberosity. So within that area, the nerve is in this very small canal before it branches out onto the perineal area. And that measures about 2 to 3 centimeters in total length, and is somewhat fixed connective tissue within there. And so looking at least at cadaver studies, they've shown that the nerve isn't necessarily free floating in there, which may have implications in terms of the physiology of what happens to it when somebody has a compression. So common nerve or common sites for nerve compression include the piriformis muscle, which isn't necessarily pictured on this diagram, but would run kind of above that sacrospinous ligament. In this zone, it's sort of sitting right up through here. The interligamentous space, so the space that travels between the sacrospinous and the sacrotuberous ligament, which in the pictures always looks much larger than it really is in real life. Alcock's canal, so again, lower down. Sorry, I keep losing my cursor. There we go. Lower down through here. In this image of a cadaver dissection, basically this pin is sitting at the level of the ischial spine, and they've opened that pudendal canal. And so you can sort of see this nerve down here branching in various ways. And that would all be covered by the canal when we're actually operating. Then at the level of the ischial tuberosity, where the nerve comes out of the pelvis and is now superficial on the skin, as well as along the inferior pubic ramus or the pubic bone, where that dorsal penile or dorsal clitoral branch travels. All right. So when we look at indications for surgical intervention, essentially refractory pain, so pain that has either failed or is just inadequately responsive to our conservative treatments. And in certain situations where, especially where we think this was related to suture entrapment, such as for prolapse repairs, you may move to decompression much quicker in the workup than typical. Things I will say about the timing of surgery is, for me, that sort of changed over the course of my career. I'm a little bit more aggressive now in decompressing early. When I was trained in fellowship, we did transgluteal, and I always felt like that was such a big surgery and such a big recovery that I really wanted to be certain that a patient needed it and or was likely to get benefit from it. So I was a little bit stingier per se about offering surgery. And then when I started doing this laparoscopically, laparoscopic surgery, generally speaking, much easier to recover from. And I do think there's less disruption to muscles, et cetera. So it may be along the lines of Dr. Boland's. He sort of, talks often about decompressing early to avoid further nerve injury. And so ideally getting to somebody in that first, 1 to 2 years, I think is ideal. You do want to do some conservative treatments because I have seen people get better from those. So not everyone needs surgery. And this is sort of that tricky zone to figure out who's going to get better with surgery. When should I offer it? What's that right next step? So the idea around pudendal decompression is that it revolves around the entrapment of a nerve either by scar tissue or adhesive bands, a narrowed interligamentous space, or even potentially vasculature, as well as suture entrapment, which is becoming probably less common. When I talk to patients about the narrowed interligamentous space, I kind of liken this area to carpal tunnel. So you have some patients or some, individuals who can get a job that they're typing and they never have an issue. And you can get other people who get a typing job and start getting carpal tunnel syndrome or symptoms, fairly soon. What's the difference? I have to surmise, I mean, what happens with carpal tunnel is basically this nerve runs right underneath this ligament right through here. And so I'm surmising, maybe individuals that end up with carpal tunnel just had a more narrow space. And I'm sort of making that same assumption for patients with pudendal neuralgia or pudendal nerve entrapment are the people who are actually getting and becoming symptomatic from pudendal nerve individuals who already had a narrow space and then had other traumas, whether it's multiple, falls that on an individual basis wouldn't have made them think of anything, but has caused kind of scar tissue over time. Is it somebody who had, a long labor or a large baby where there was a lot of pressure as the head descended through that area of the pelvis, things like that. I think vasculature is something that we probably are overlooking a lot. I've seen a few patients in the last year that sort of have symptoms of pelvic congestion syndrome, where it's like varicose veins in the pelvis that can back up and put more pressure on areas. And of course, again, the pudendal nerve travels through that narrow canal. So if you have a dilated vein, it's going to take up more space in that canal and it's going to compress the other things with it. And so sort of the question of, okay, well, how much vasculature like that versus our pelvis is very individual, shall I say. Like there's a lot of different anatomy, and the more I do this, the more I appreciate how different every pelvis is in terms of how the nerve branches, what's around it as we go higher up. And so I think that also is something that's happening, and we just don't have good enough imaging to really be able to determine again, where a site of compression is. So when we look at, okay, well, what's normal versus what's pathologic, when we look at surgery, we don't really have a reference. So the only people that we are operating on that maybe aren't symptomatic are typically cadavers when we're trying to understand that anatomy. But otherwise, we're only operating on people or individuals who are symptomatic. And so it starts to become hard to say, well, all of these people had symptoms, so can I really call them normal? What I have sort of found as I've done individuals that have bilateral symptoms, often one side is much more straightforward than the other. And that sort of serves a little bit as my control when I go, okay, that side might have been just more what normal anatomy is versus an entrapped or scarred nerve. But we don't have great data around that. So when we look at surgical approaches, there's multiple. So transgluteal is probably one of the more common ones. So that's essentially the larger incision along the buttock, following the length of that sacrotuberous ligament. And that's a big surgery just because it already hurts to sit and now you have a big incision there. But that's the one we have really the most data with which to comment about this surgery in general. There's now endoscopic transgluteal, where people are actually putting ports in the same way that they do for laparoscopic surgery, and dissecting that similar manner. There's laparoscopic and or robotic. I will approach this both ways, just sort of depending on unique patient factors. Ischiorectal, where basically you're kind of getting deeper, and this is often a little bit better for that rectal branch, which runs lower down. And then perineal, which is this left-sided picture. The circle here is the level of that ischial tuberosity or your sits bone, and then they sort of draw out sort of what would be the rough direction each of those nerves would go. So tonight, we're predominantly talking about the laparoscopic approach. This is just sort of another slide discussing the zones of entrapment. So where the nerve could be entrapped and what's the potentially best approach for that. So, every approach has its limits. A perineal approach is not going to be able to necessarily access deep in the pelvis. A laparoscopic approach is not going to be able to access on that perineum. So it's really important to utilize patient symptoms, your physical exam to help guide you where you think that entrapment might be, or patient history in terms of how do we think that this happened, to sort of guide us on what's the right route. So the laparoscopic technique was first described by Dr. Mark Passover of Switzerland in 2009. The advantages of this is that laparoscopy is very familiar to many of us. So gynecologists for sure, urologic surgeons, it's easy to take what we already do well and do every day in the OR and now transition it to essentially pelvic neurosurgery. You have more visualization of all of the endopelvic nerves and the sacral nerve roots. Let me move this. So, not only can I access the nerve basically from where it starts along through a portion of this canal, I can actually get up to the nerve roots themselves, which are potentially another player and maybe more of a player than we realize in some of the individuals that are failing nerve decompression surgery. The differential diagnosis in terms of what we're thinking is causing the pain can be directly evaluated. So if we see a vein or an artery crossing in a unique way, we can essentially deal with it right then, and we can get good visualization. And there's overall minimal risk of postoperative pelvic instability, whereas the transgluteal approach, you're actually cutting both of these ligaments. And the sacrotuberous, this larger one, is thought to be much more important in pelvic stability. And so when they're doing the transgluteal technique, that ligament is actually sutured closed. They leave the the sacrospinous ligament is cut open to allow more room for that nerve. So this is sort of a side shot of the nerve coming down in the sacrotuberous, which is that ligament in the back, the sacrospinous ligament in the front. So basically we open this one up, fillet it open so that there's a nice space for that nerve to run. And then it runs into that Alcock's canal. So there's a little kind of opening here that essentially you can cut open or dilate and try to take that down as far as you can. So it provides a large segment of nerve for us to identify and free up. The disadvantages, arguments are that it disrupts the pelvic floor musculature. This is overall a relatively small amount of disruption of what actual muscle is being cut. I think personally, compared to the transgluteal approach, you're not really damaging pelvic floor, but you are doing a lot to the gluteal muscles. So I think it's, again, that balance. There is increased injury due to adjacent structures. So everywhere a nerve runs, an artery and a vein run with, and the pelvis is full of a lot of veins that are crisscrossing in different directions. Again, everybody's anatomy is very individualized. So you have to be very focused and paying attention to what structure is there. And it also requires increased laparoscopic skill and knowledge of that deep pelvic anatomy to be able to do this procedure safely. General risks to surgery are, mostly your general surgical risks, the things that you hear for anything like an appendectomy or your gallbladder: risk of bleeding, risk of infection, risk of injury to nearby structures. So, typically, risk of bleeding is generally pretty low. Like I said, vessels travel all over through there, so you do have to be very cognizant of those. Infection, relatively low risk. Typically not a procedure that you absolutely need to give antibiotics for, because you're not opening any spaces that contain bacteria. And then injury to nearby structures. So one that is probably more commonly affected is the obturator nerve. And you'll see this in the video clips that I have. To get into the deep space of the pelvis, we basically have to free up and identify the obturator nerve. And depending, again, on an individual's anatomy and essentially how our instruments are coming through, sometimes there is pressure put on that nerve, which can lead to a stretch injury. And so patients can wake up with weakness of their hip adductors, so trouble walking, trouble having that stability. They may initially have some numbness or tingling or distinct pain in the inner thigh. And that's, again, related to that stretch on the nerve. But it's because it's not in a cut injury or a thermal injury, it will typically recover over the course of those 12 weeks. But obviously that's already a trying time for patients that have undergone this procedure. Their pudendal nerve is irritated from surgery. And so it can be really difficult when you add in the potential irritation of the obturator nerve. Even though I can safely say it's going to recover, that can be challenging. So the laparoscopic technique typically takes about an hour and a half to 2 hours, again, sort of just depending on what's going on, how scarred things are. If I'm doing both sides, it's usually 2.5 to 3. And essentially, this stepwise is just sort of here for reference. Again, I'll go through this in video, but we essentially are opening what's called the retroperitoneum. So our abdomens are lined with this basically skin type tissue that keep all the organs housed. Behind that tissue is where our muscles, our nerves, our blood vessels are all running. And that's where we're opening to essentially identify these nerves. It'll make sense here in a moment when I show the video. We find that that obturator nerve mobilize that to try to keep that safe, and then find the pelvic sidewall. So find the muscles of the pelvic floor that your physical therapists are manipulating, and work that down until we can find that sacrospinous ligament and that ischial spine. And once we find that, then we start to basically open that up. So very briefly down here is an image of the sacrospinous ligament. We trace that right to the ischial spine, which again, you can typically feel with your instrument. And we open that up essentially right next to the spine as close as possible, because typically that nerve, artery, and vein will run underneath the spine. And then once we open that up and we can identify those structures, we trace those into Alcock's canal so that we can kind of dilate that area open, transect a little bit of the obturator nerve or that fascial overlay to be able to give that nerve more room in Alcock's canal as well. If you see branching of the nerve, then ideally we dissect out each of those branches, or basing that on an individual symptom. So if I know somebody has a lot of, heavily rectal symptoms, I'm going to be very focused on looking for the rectal branch. 50% of the time that will happen before the nerve goes into Alcock's canal. 50% of the time it'll happen after Alcock's canal. So in not every case can you actually access each individual branch. Okay. And so here we can palpate the ischial spine and we can identify ligament overlying. And then this is where we've cut open that ligament, and you can just very briefly sort of see this bluish hue coming through here, which is the vein. Vein and artery, I guess. So, okay. So let me try to exit out of here. And reshare. Okay, so this is a very rough video because I don't do a lot of these, so I'm working on piecing it together. So over the course of, I'll probably speed through some of this, but this is that peritoneum that I was talking about. So very quickly, we are grabbing one of the ligaments. Oops. And opening that peritoneal lining. And then we start dissecting deep within here. So this is actually, and I'll hit pause here. So this is deep in the abdomen. This is the obturator nerve that I was talking about. This is actually probably I think in this patient, this was the vein traveling along here. So we free this up so that we're ideally not rubbing across it as we try to perform our surgery. So freeing that up. In this instance, we've now dissected, essentially, this is our pelvic floor. So this is some of the obturator and below this levator ani muscle. And so I have my fellow with their finger in the vagina, basically trying to feel the sacrospinous ligament and the ischial spine. This was something I did more when I was first starting to do these to sort of help understand what that anatomy was and make sure I was in the right spot. So she's feeling that right at the tip of my cursor. Then we open up that tissue along through there. We typically dissect off what's called the coccygeus muscle, which sort of travels. So you can see all these pink fibers. And that white stuff underneath is actually that sacrospinous ligament. So in this patient, the spine, ischial spine, is right here. And we are basically taking these scissors and hugging up to that spine to cut the ligament open. And the reason we do that is because, again, the nerve and everything runs right underneath that spine typically, so it gives us the best access. In this frame, we have this instrument on the left actually holding a portion of the sacrospinous ligament. We can see a little band here that I'll open up later. And so now I'm sort of exploring that area underneath. This, I'm sorry, you guys have to deal with my editing skills here. This is just as we're going deep into the pelvis again. So we've got the obturator nerve, obturator artery, obturator vein coming through here. And then we are traveling deep, deep down. And so in this frame, you can start to see these structures. Pause it. Bring this back just a little bit. So right here, you can see these linear structures starting to appear, and that's the neurovascular complex. So again, the ischial spine is kind of right at the tip of my white instrument, and underneath are running those key structures. And so then once you've identified, really the hardest part is getting to the point where you can just identify those structures. And then once you do that, you're essentially just working to free them and move them away from that space along that bone, so that they have enough room when the patient changes positions, is sitting, there's room for that nerve to move, so that it is less likely to be being pulled and compressed against that bone. Let's see. And here's where I'm kind of saying, oh, I have a little bit of ligament yet to open. So dissecting that. So again, you can start to see more length here. And you can see the camera shakes quite a bit during this because really the area where we're operating is about the size of a silver dollar. So you're taking instruments from outside the abdomen and they're coming in at a triangle and you're operating in this very, very narrowed space. So you're constantly hitting the camera and trying to work around the angles to be able to see things. So that's why it's a little jumpy. But all right, going deep into the pelvis again. So in this instance, in this individual, the nerve is sort of this more medial area, and I'm now trying to dissect the nerve away from the artery and vein in case there's compression by those structures as well. Now, again, having my fellow repalpate to make sure that they don't feel any residual ligament left. I think in this section, I knew I had a little area up here. But that was something I did early on too, just to sort of feel and make sure, okay, there's nothing that feels tight through there that I should otherwise be opening. I now do this a lot more visually. In this case, I'm coming up higher. Let me pause here. So this in the middle of the screen here again is the obturator nerve. This is a portion of artery coming off, and you can see all of these little spider web areas, which are just connective tissue that's holding everything together, which is always present in this space. But you can see a lot of these little veins kind of coming off in different directions. And so what I'm looking for, and I've sort of taken this from Dr. Boland's videos of looking for the pudendal artery to start pulsating again and using that as my guide, that I have most likely freed up whatever compression was there. The artery is obviously always pulsating. It's always sending blood down through that area. But when you free it up, you suddenly start to see it from going like this to really pulsating or really pounding. And so I try to make sure that I'm seeing that on my surgical cases so I can feel good about, knowing that I've gotten that compression. A lot of times you really don't know that you have got the compression until you've opened it up sometimes. And sometimes it was the ligament, and by the time you open the ligament up, you've already freed things. And so that can be sometimes challenging in terms of knowing what to tell patients. Here is an after, and you can see if I stop touching this, that you can see the artery pulsating really well here. And I'm just trying to take this as deep down into Alcock's canal as I can. This is one limitation of the laparoscopic approach, is that the angles only work so well. So that nerve continues to travel up on the screen, but my instruments, I can't really change the direction that those instruments are traveling. So I go as high as I can. With a robotics approach, you can get deeper in there. And because your instruments have wristed motion, you are able to get a little bit deeper. And like I said, I do approach this both ways, just depending on the patient situation. And there I pushed it a little far, so I got into some bleeding in that canal. So I have to work that further. Now, all of kind of this like red beefy tissue here is muscle. So I am doing a little bit of disruption to some of that pelvic floor musculature, unfortunately. And we try to limit that as much as we can, but yet still getting the job done that we were there to do. So This is an aftershot. So in this section, we've got nerve, that whiter structure in the middle. We have artery on top of it, and then we have the vein coming in from that right side. What we previously had, so we have this little charred area, which is the ischial spine. We have this little charred and white area, which is the ligament that used to stretch across that area. And now we've moved that nerve, transposed it from completely underneath that spine to a little bit more medially, or like closer to the vagina for reference. So that nerve has more space. And so when someone is sitting or in certain positions, they aren't getting the pull or the pinch on that nerve. And then you can again see that artery is pulsating nicely. It's nice and free. And they are mostly freed structures, again, as far as I can kind of take that. So let me pause there and we will go back to slide. Okay, so when we look at recovery from this surgery, it's somewhat dependent on the surgical route. So, you know, in general, we say 6 weeks for recovery from any procedure. The reason we say that is because it takes about that long for any tissue, particularly the fascia, which is that strongest layer of the abdominal wall or pelvic floor, to heal at its maximum. So beyond 6 weeks, it's not going to get any stronger. And so at that point, your risk of hernia pretty much levels out. And that's why we let you to return to activity around 6 weeks. Along with pelvic floor PT, usually we're just giving things time to kind of settle. The transgluteal approach, definitely, again, a little bit harder just because of the size and the location of that incision. But at 6 weeks, generally I'm saying, okay, you can start, you know, doing lighter exercise again. You can start lifting things if you need. You can get back to physical therapy. When we look at really nerve recovery, though, that is a long, slow process compared to typical surgical recovery. Nerves, when I was in med school, we thought nerves didn't heal. It was like once a nerve is damaged, it's dead. And over the course of time, we've really learned that no, nerves do heal and regenerate, but they're slow. And that's part of the challenge of this surgery, is that it's a slow process. The earliest, I borrowed this again from Dr. Boland's, but it was a nice graph that I actually include in my my post-op instructions, just as a visible reminder of like, this is the path that you're on. So, earliest improvement, somewhere around that 4 to 6 month window, is typically when people may be starting to notice that, you know, oh, I can sit for a little bit longer, or I'm not flaring quite as much as I used to. And really maximally, at least by Dr. Hibner's data, by about 18 months. I know he has 24 months on this slide. So it's somewhere in this like 4 to 18-month window where you probably are seeing that most of the recovery. There are patients who notice immediate improvement in pain, even in the recovery room. That's relatively rare. Some of it might be just the effect of the anesthesia on the nerve. There may also be, you know, if there was an area that was really significantly entrapped, just by releasing that entrapment. And the individuals that I've seen report this are individuals that had a very clear, dense scar going across that area. Short term, you know, some patients may kind of get some early short-term improvement. About half will get what's called reinnervation pain, or something called allodynia, where you have pain to non-painful stimuli. So this is where somebody can touch your skin with a feather and your body isn't interpreting it as pain, even though you know that that shouldn't hurt and it doesn't hurt anywhere else. And that's because that nerve is sort of healing and those neurons are really firing a little bit more than they had been. And the phases of improvement, again, kind of borrowed from Dr. Boland's. I'm not seeing this in all of my patients. I've seen 2 that have had kind of a numbness type sensation that initially wasn't painful, that progressed to kind of pain, and then that returned to more normal sensation. Most of my patients are within under the 1 year mark. I've seen a few now getting out, near that 18-month mark. So again, sort of borrowing what I know of this surgery from him and from Dr. Passover and others who have been doing this longer than I have. But I'm seeing kind of similar. And it's obviously really important in that recovery timeframe to continue to avoid activities that increase your risk of falling or increase that compression. So you don't want to go back to just sitting, being like, great, I can sit for 8 hours. You don't want to do that right away. You still want to be careful. If you're a cyclist, you maybe want to look at trying to find a different sport. Certainly some people decide this is worth it to me. I need to do this activity for fulfillment. And, in which case do it, but that you're doing it with, with risk. When we just look at kind of general outcomes, they're typically what's reported out there is typically pretty good. 60 to 80% of patients will get improvement. Now, that is important to know that that's improvement and not pain-free. So looking at, again, Dr. Hibner's literature, we used to quote that about 30% of patients may end up actually pain-free, 30% will have improvement. 30% will have no benefit, and about 1% of patients with worsening pain. Most data, whether you're looking at laparoscopic, transgluteal, or any of those other approaches that I was commenting on, that 60 to 80% range is 60 to 80% of patients that undergo this surgery will have improvement. Now, what's important to look at is that's not any and every patient. What sort of is the most predictive of somebody getting success with this surgery? And of the studies that have been out there, really the biggest one is positive response to an anesthetic block, meaning if we inject and numb the pudendal nerve, you get pain relief. Even if, let's say, it's for 6 to 8 hours, it's only the duration of the numbing agent that was injected, that's still a positive sign. That still tells me, hey, the pain is traveling through this nerve. What it doesn't tell me is where is the issue. And that's our biggest challenge. But looking at a study from Waxweiler in 2016, individuals that did not respond to an anesthetic nerve block, all of them failed surgery. So no one got better, which makes sense because if you numb the nerve and you get skin numbness of the area that tells you, yep, I hit the nerve, it's numb, but they're not getting any pain relief, that's probably not a patient that should be having that surgery because the nerve is not compressed, at least in that area. Some people have looked at duration of symptoms, either, those that have had this going on for more than 4 years in one study or no difference in terms of duration. It certainly makes sense. The longer a nerve is compressed, the less likely it is to recover. So again, tending to try to intervene earlier. Pain involving the dorsal clitoral branch, because one, that's the longest portion of the nerve. There's more sites for that to be compressed that may not respond to surgery as well. Individuals that have sensory deficit, meaning they're actually numb to physical touch of the perineum, that actually suggests that maybe it's more your sacral nerve roots or your sacral plexus being involved as opposed to the pudendal nerve. So again, that's just picking the right patient to have the right surgery. They have not seen difference in men versus women, one-sided versus both sides, or age. And all right, that looks like the end. So that's kind of that quick synopsis. Other things to sort of share is, that post-op recovery is obviously, again, hard for patients. It's also hard for us as the physician because we're sitting there with you going, gosh, I hope they're going to get better. Are they going to get better? You're waiting 6 to 12 months to sort of see if what you did is going to help this individual. And you're also trying to figure out, how do I still help them while we're a little bit more hands off? Because the last thing we want to do is continue to do things to this nerve while it's trying to heal itself, right? So maybe some nerve blocks reasonable. If the pelvic floor muscles have really tightened up and are tense and we think are contributing to pain, yes, we want to treat those. But otherwise, we really just want to be hands off and let that nerve heal and recover. And so that may mean, though, increasing medications, even though, again, a lot of people are doing surgery because they don't want to be on medications for longer duration. We may need to bump it. We've aggravated this nerve by operating around it, and it needs a little bit more support. And after that 6 months or so, you can start sort of weaning stuff back and seeing, okay, how are we starting to respond? So I know it sometimes feels like, okay, well, the doctor did all this stuff up front. Now they did this surgery and now they're not doing anything for me. There is a reason for that. And it's again, it's a fine balance. And again, everybody's post-op course looks different. But that's, I know that's one thing I struggle with, is just going like, trying to find that sweet spot between doing enough to help manage someone's symptoms through that time frame and not doing something that's going to cause more harm. So with that, Cora, I'm happy to take any questions that have come through on the chat, etc.
All right. Well, thank you for that. That was a great presentation. I did have a couple, just to verify a couple things in the presentation, because I'm not sure if I heard it or,
You're good.
um, let's see. For the blocks that you mentioned, you said that, if you have a successful block, the odds are a little bit better you have surgery. Does it matter what kind of block it is, like if it's vaginally done or if it's done through the glutes?
I don't think it matters. I think it's just, how do we get that nerve numb? And I can say, at Cleveland Clinic, trying to figure out, okay, who's my team? Who's going to get the best results on these blocks for me? I can't always get patients in the office to just do it myself in a timely manner. So sending people to IR or pain anesthesia. And we don't even have good literature on what's the best block to have, but any block that numbs that nerve and gives us a pain response is an adequate block.
And then you mentioned pelvic floor therapy is okay, and I think you said after 6 weeks, or
I
was it?
usually say 6.
And that includes internal physical
Mhm.
therapy? Okay.
Mhm. Yeah, again, we want somebody that's going to be gentle around that area, but is working with the muscle. And sometimes, again, those muscles get aggravated from the surgery itself. So,
And then, so you mentioned how you're a little bit more aggressive with going towards surgery now. I noticed a couple patients saying, well, if they're having some success with managing the condition with medication,
mhm.
would you still suggest they go towards surgery due to that cap,
Mhm.
or is it case by case basis?
I think it's really case by case. It's, what's the severity of your symptoms? Are you 83 or 43, right? And how much are your symptoms limiting you from doing what you need to do? And knowing that, we can always change the game plan. I have some patients who come in and who are very like, no, I cannot continue to do this, or I have such side effects from medications. I just can't imagine being on these. I really want to move to surgery first. And then other people are more wary of surgery, and maybe people that have had surgery and that's what caused the condition. And so everybody's different, and I just take it very individual.
Okay. And then I vaguely recall you mentioning the clitoral
Mhm.
portion. So I know
Mhm.
a lot of our patients have PGAD, for instance. Would decompression surgery help those patients, or have you had patients with PGAD and have
Mhm.
you noticed anything?
I can't say I've done enough individuals with that myself to be able to speak to it. I mean, again, we don't really know what is causing PGAD. Is it an issue where it's actually a vascular thing that's going on that's causing entrapment, etc., or is the nerve entrapped and then firing on those blood vessels that are traveling with it? We don't really know. I certainly think it's reasonable to do. It's still something that I would offer. And it's not that I don't offer surgery to people that have clitoral involvement and pain. They're just, based on the data we have, maybe less likely to get improvement in that section of the nerve is
Okay.
all. So, but it doesn't mean that you don't do surgery.
And some patients wanted to know, would you operate on someone who has previously had a failed decompression surgery?
Mhm. I have so far done one repeat of somebody that had a transgluteal. I have another person coming up later this fall. It is uniquely different because you don't have your anatomy anymore. They no longer have that ligament, and things have sort of walled themselves off, or reperitonealized is the verbiage that we use. So it's a little harder to find structures. And so that's something where I'm deciding, I might switch to a robotic approach for those individuals, just to be able to do much finer dissection. Um, but yes, still something to consider, because the question is, was there something higher up or maybe lower down? I mean, you certainly can access a lot transgluteally, but I think it's reasonable to at least offer.
And someone asked, why do some surgeons claim that they can access the entire length of the Alcock's canal with the laparoscopic approach?
Mhm. I mean, you probably could to an extent if you're really going to disrupt that entire membrane. Again, I find it a balance, and sometimes there are just situations where again, the angle with which I'm operating. So I kind of describe laparoscopy like operating like Barbie. So your arms do this, and you have to get the triangles to line up to be able to get the tension on the tissue. And if there's a bone there, you can't get around that bone. Whereas with robotic, you have more motion than the human hand. So you are able to get down and lower. And so I do think in that setting, robotic laparoscopy, you are able to approach that more. If again, I were to really disrupt all of that overlying muscle and fibrous tissue, I probably could get down there. It's that figuring out that balance of, do I need to, or am I going to cause more damage for this individual? And so I think that's where in the next phase of my building a program at Cleveland Clinic, I sort of want to now get an injection at the ischial spine and injection deeper in Alcock's canal to potentially help differentiate where that compression might be.
Okay. And then I'm almost positive you you did
I
this.
went fast. I went fast. You're good.
So for patients with rectal pain, are
Mhm.
you able to trace the inferior rectal branch laparoscopically from the main pudendal branch? And if so, how far?
Mhm. Again, very individualistic in terms of people's nerves branch in all different ways. So it is something I'm looking for, particularly when someone has rectal symptoms, as I'm dissecting that out and looking to see, do I see a branch coming off? Again, 50% of those nerves will branch somewhere deeper within Alcock's canal. And so that may be a situation where you can't, again, easily see that. So I think, again, over time, as I start really aggressively trying to understand what's the best approach for each individual patient, that may change in terms of how I do the procedure.
And I know you mentioned you used to do transgluteal back with
Mhm.
Dr. Hibner. Do you
Mhm.
still do transgluteal or just laparoscopic?
I do just laparoscopic now. Part of it is just the struggle with having changed hospital systems and, gynecologists doing procedures that are unique to gynecology. So this is a little bit easier for people to support what you're doing. And it may be something that, again, do I bring back? But I really feel like generally my disruption to the pelvic floor is relatively low. And I can see a lot more of the nerve. And so I personally think I do a better job this
Okay.
way.
And then let's see. And then just so people know, for patients traveling to Cleveland Clinic for surgery,
Mhm.
do they have to stay a certain time frame with your surgery? And then do you see them back in your office for like a post-op appointment?
Usually I don't necessarily require patients to stay locally for a set amount of time. Some people stay overnight in the hospital, other people decide to, just stay in the hotel nearby, and leave the next day. It's quite variable. Local patients, even that are, a few hours from Cleveland Clinic, travel home that same day, because the likelihood of any major, event is small. And then I just see people at 2 weeks, or my nurse practitioner sees you virtually at 2 weeks. I see you either in person or virtually, typically virtually at 6 weeks. And then basically at 6 months, 12 months, 18 months is sort of what I'm trying to get.
And then are these patients that you have, are they being treated by you in terms of medication, or do they have a pain management doctor in their own state that, kind of
Depends.
follows
Probably
up?
purely out of state patients usually are going to have local pain management because I wouldn't have been doing their pain management whereas patients that are local, a lot of times, right, we're the ones that are initially making the diagnosis, that are doing that conservative management and getting to them to the point of surgery. Whereas patients that are coming from out of state are coming with the diagnosis and usually have someone. So
All right.
varies.
And then we have a couple, and I'm going to get to the ones on here. Sorry, we have so many.
Mhm.
Um, let's see. Do you require any specific imaging before surgery?
I like to get an MR neurogram which we have at the clinic, just mostly to rule out anything larger, deeper that we may be not able to feel on exam. Most of them are negative. Every once in a while, I get something that pops up that, doesn't even always correlate with the patient's symptoms, to be honest. But I do like to make sure that anyone I'm taking for surgery, I have that just to dot the I's, cross the T's. It also helps my radiologist get better at reading these so that hopefully over time, they are better at picking things up as well.
And then what's your opinion on radio frequency ablation?
Mhm.
And do you recommend it or not?
It's definitely something that I talk to people about when I'm making the diagnosis. You specifically want to look at pulsed radio frequency as opposed to conventional. Conventional is basically where they heat the nerve up with the intent to destroy it, whereas pulsed is warming, cooling, with the intent, essentially, I say to scramble the signal, kind of like, um, you know, not going to train off the track essentially. So I think that it can be useful, especially in patients that maybe, aren't a good surgical candidate for some reason, don't want to have surgery. It may last longer than a nerve block. The challenge, is finding somebody that does it. So I don't even have anyone at Cleveland Clinic that will do pulse radio frequency, for patients. So I think that's a unique challenge. I'm not personally a fan of cryo ablation. I've seen a couple of people that have had that done that have not, done well. I always have to say that the caveat is right. I'm not seeing the people who are doing well. If they had a thing done and it helped them, they're not coming to my office. So I am a little bit biased from that standpoint, but
And I noticed somebody also asked, do you ever recommend it before surgery? I presume this would be something
mhm.
after surgery fails.
Not necessarily. I mean, again, it's upfront when if you want to look at more invasive options. So let's say you got nerve blocks, but you're not getting longer lasting relief from them. Then I basically talk about radio frequency ablation, nerve stimulators, and nerve decompression surgery. And so again, depending on the individual and what their goals are, et cetera, that's something for them to pick. My biggest challenge is just not having somebody to easily refer to for that.
Okay, let's see. So now I'm going to go through some of these. Let's see.
And I will have two little kiddos coming back at some point here, so it might get real loud.
No worries. My kids are walking around as well. I
Okay.
understand. Um, can you tell where the entrapment is based off of symptoms?
No, unfortunately, not always. So sometimes on exam, you can basically kind of tap along the nerve and sort of find where patients go, ooh, like I get a zinger when you're there, which will sort of help guide the idea of that's where an entrapment is. But because everybody's nerve branches in such varied ways, it's really challenging. I used to think like, okay, well, if it's above ischial spine, they should have all three nerve branches impacted in terms of the sensation difference, but that's not necessarily true because again, those nerve fibers travel actually in different areas of the nerve too. So you can have one area that's compressed and not have symptoms through the whole nerve. So unfortunately, no, we're not very good at that yet, either with history, physical exam, or imaging.
Okay.
It will be better soon.
I know this is a popular question given the fact that you're OBGYN, but do you treat men?
I do not currently. So I have been giving some lectures with urology. They do certainly some of the, nerve blocks and things like Botox injections. Um, I am working on some of our interventional radiologists around the idea of pulse radio frequency. We do have a neurosurgeon at Cleveland Clinic who does transgluteal approach. Megan Jack is her name. So that's a route that I send men is to a couple of our urologists, Emily Slopnick and Lee Wong Roberts, and then potentially Dr. Jack for surgical discussion.
Okay. And let's see. I noticed there's kind of a pattern here. So, if people have had pain for a longer amount of years, do you think it's too long for a good outcome? Have you had any patients that have, let's say over 8 years?
Mm-hmm. Mm. there's not anyone that I can think of specifically in my brain from that standpoint. Again, it's, by the time often you're getting to surgical decompression, right? It's a last ditch effort for some people. And I personally am willing to take that last ditch effort to give you any improvement if I can. But I'm going to counsel you up front on like, okay, these are the things that maybe aren't in your favor for this procedure. And then you make that decision of, okay, does that sound, not worth the risk to me? But as long as, again, you are still having a positive response to a nerve block, right? If you had your last nerve block 4 years ago, well, I don't know, has there been more damage since that time frame? I want an updated nerve block to know that, yes, okay, I still get pain relief from that. So I can use that to say, okay, there's still potential for surgery to benefit.
And off of that, for your out-of-state patients, would you like them to get the initial nerve block and diagnosis with you, or do you take it from other doctors?
I'll take it from other doctors because again, I'm not necessarily doing any other testing to prove that the nerve block worked other than the patient telling me like this is how long I got pain relief and it was 30%, 50% improvement. I got complete pain relief while I was numb. So I don't think that needs to be done at Cleveland Clinic. For those that, haven't been able to find somebody to do a nerve block. They're suspecting they have the diagnosis of pudendal neuralgia. My care coordinator is trying to look and say, okay, they're from out of state. They've not had a nerve block. And she tries to line up a block, or we're working on that, but a block, the MR neurogram and the appointment with me all at once so that patients aren't having to come back and forth.
Okay.
Well,
Let's see. I'm actually so do you always recommend Botox before surgery?
not necessarily. So if I have a patient whose pelvic floor on exam is very non-tender and not bothering them, I don't think there's any benefit per se for Botox in that situation. For patients that have tight and tense, tender pelvic floors, yes, I do recommend it because you're trying to figure out is the chicken or the egg. So is it the muscle that's tight that's pinching on the nerve, or that's causing the pain, or is the nerve irritated and making the muscle angry, etc. And so I'm not, if I'm not fixing your pelvic floor or decreasing some of the tension there, I'm also not fully helping your pain situation. So sometimes it kind of helps differentiate which of these is the predominant pain contributor. But I definitely have people who are not tender anywhere in their pelvis except for along the length of that nerve.
And what would you suggest? I know this is sometimes an issue for a lot of patients. What if you've gotten multiple blocks and let's say like 4 or 5, but only one worked? Is that
Mhm.
still considered to be positive? Because sometimes I know, doctors can miss and things
Mhm.
like that. So as long as they have that one block.
I typically use that because yeah, I mean the studies that we do have show our accuracy at getting all 6 nerve branches, if you take 3 on the right, 3 on the left, are not great no matter how we do this. And so I do often ask like, were you numb? Did you have a little bit of decreased sensation with wiping? Because if, again, if we numb a nerve and you still have pain, then it's probably not that nerve causing the issue. But if you're not numb, I don't know, did you not get pain relief because we missed the nerve or because it's not that nerve?
Right.
So, and I will have to wrap up here, Cora, because I can hear little ones
Sounds good.
outside the door here.
Let me ask this. So have you considered using any nerve wrap to protect the nerve from scar tissue that may form after surgery?
I do not typically right now because I'm still going to be there's space in that area. So I don't think we have, I mean, we certainly don't have any evidence. We have no studies looking at the use of nerve wraps and is that positive or not for this nerve. I think, right, in neurosurgery, they use nerve wraps typically when they have a nerve that's been cut in half and they're trying to get it to grow back together and decrease scarring. The one patient that so far I've done a repeat decompression on was somebody who had, I believe, a Neurogen wrap on the side that we re-decompressed. I mean, certainly, again, it was all encased in fat and it's kind of I mean, scarred is a loose term. It was encased in other tissue, but not necessarily restricted by that tissue. Um, so I'm not currently using them. That may change with time,
Okay.
the long and short of it.
So I know we didn't get to everybody's question, but I just wanted to say thank you, Dr. Gubbels, for sharing your time, insight, and compassion with us today. Um, it I think it brings people a lot of hope and clarity. And it's a navigating some of the most complex pain conditions when it comes to nerves. And we're truly grateful for your leadership, your advocacy, and your commitment in patient-centered healing. And it's been an honor to speak to you.